Academy of Pediatrics, myself, Dr. Shraddha Khilate,
and myself, Dr. Sanjeti Patil,
welcome you for the 10th Annual Conference Kapicon 2024, Achieving Excellence, Expanding Vision. We hope that this conference will provide a platform for people to interact with experts in a wide range of fields within the pediatric community. We are looking forward for your active participation as well. So ladies and gentlemen, fasten your seatbelts as we begin with our academic adventure. To maintain the decorum of the program, I request respected delegates to kindly keep their cell phones on silent mode. So as the world celebrates T20 World Cup, let's welcome our opening batsman for today, Dr. Sagar Varankar sir, to deliver his talk on allergic rhinitis from sneeze to breeze. To chair the session, I invite senior pediatricians of the town, Dr. L.B. Swami sir and Dr. P.G. Patil sir.
One and all, very good morning all. Thanks for inviting me for organizing committee. It was very difficult task for me today morning to reach and get ready within 10 to 15 minutes.
Hello, sir.
And somehow I managed.
Hello, sir. Good morning. Just I will introduce in short.
Oh, is it?
Dr. Sagar S. Varankar is pediatric allergist, pulmonologist, and sleep specialist from Mumbai. He is attached to SRCC, Apollo, and Jupiter Hospital from Navi Mumbai. He has many national, international publications, and he is taking us from wheeze to breeze, and for this I request sir to start his deliberations.
Thank you so much. I'm sorry. Because we are running late, I thought I'll start early. So topic given to me is sneeze to breeze. Why this picture is here? Why this picture is here? So in April month, I went for advanced bronchoscopy workshop and training program in Düsseldorf, Germany. And you can see beautiful pictures of me here. But I'm not showing the beautiful faces there, but what I wanted to show is, look at my eye. Okay? So I myself is very much allergic rhinitis person. I'm having allergic rhinitis, but now it is in control. When I was studying in Mumbai, till I finished my MBBS, nobody knew about allergic rhinitis and all these issues, and all issues regarding allergic rhinitis. Then I went to do my post-graduation in Kanchi Kamakoti Children's Hospital. I made Dr. S. Balasubramaniam my teacher. I owe everything for him, and Dr. late K. Nagaraju. I started my journey from allergy and pulmonology from these two stalwarts. He did allergy testing on me, way back 14 years back. See my eye. It was terrible time for me because temperature dropped down because of so much of rain, pollens, and I had so much sneezing, rhinorrhea, 3 days during my training, even in hospital, I was just literally. So the topic is implication of allergic rhinitis. What happens when you have such terrible features? You get anxiety, depression, like how I'm going to complete my training. Then, self-esteem, because all the time you are, cleaning your nose, horrible time. And of course, for children, healthcare costs and their families, as well as loss of productivity and absenteeism. But I didn't skip my lectures. So let's begin. So that's what I wanted to tell you, what happens with allergic rhinitis if you don't treat it properly. Thankfully, I had my medication along with me, so I could get better immediately. So here is a 4-year-old Master F, frequent cough, cold cough, which is dry, more at night, with variable periods of cough-free intervals, rubs his nose, sneezes often with persistent of nasal symptoms, episodes seldom associated with fever, no snoring, mouth breathing, but no history of wheezing. Father is known asthmatic. Growth normal, everything is normal. Ear erythema but no bulge. Nasal congestion with clear fluid, throat congested. Temporary stuttering. So most important points to note in this, how to recognize whether this is allergic rhinitis or not. Child with increased frequency of symptoms, one or more contiguous anatomical site like nasal, pharyngotonsillar, ear, laryngeal, tracheobronchial, And of course, we have to look for temporary stuttering of growth and development, because they frequently get hospital visits on medication. So you need to follow that, because they can't sleep properly, and reduced sleep causes irritation and food habits changes. They become more pampered and irritable so that is very important because of decreased appetite, sleep activity. So, and occasionally you need to find out red flags, like if it is continuously from the beginning of their newborn period, then you have to think about something like cyanobronchial syndrome or something like PCD, that is primary ciliary dyskinesia. So last 2-3 months I have been diagnosing PCD a lot because of, maybe we have the genetic testing available. Another case, 12-year-old boy, history of breathing difficulty, cough, fever. So you can see his saturation 88 without oxygen, fast breathing is there. These features, past history of 2 similar episodes, this gives idea there is something called as asthma which is happening. And along with fever, so acute asthma with viral fever. But if you go and deep into the past history, he had 5 to 6 years, he had frequent episode of cough and cold, for which he used to take frequent nebulization. Later he was all right. Until 6 months back, he had first episode of severe wheeze. In between these episodes, he is having wheezing, early morning and stuffy nose. On inquiry later, found to have some building work going on in his school premises last 7 months. So you know that this is the diagnosis of allergic acute asthma, but it's mostly exacerbated because of allergic rhinitis, which is hidden part. So wanted to tell you that allergic rhinitis is like a ghost diagnosis. We have to find out whether it is there or not. Sometimes it may not be so profound to come to your notice when in your busy practice. 7-year girl, snoring, coughs, constant mouth breathing, frequent episode of upper respiratory tract infection, referred to ENT clinic for evaluation of adenoidectomy. But patient came to me because they don't want to get operated. This is normal for all pediatricians. Parents reported 2 years of constant nasal blockage and colds which had worsened over the time. She had bouts of sneezing attacks that were more frequent in rainy and winter season. Yes, family history is asthma and allergic rhinitis to both, some allergy to the both parents. On examination, chronic mouth breather with pronounced allergic shyness, blocked nose, large inferior turbinate, grade 3 tonsils, few expiratory wheezes on auscultation. So sometimes when there is so much of secretion inside, and if you ask the child to breathe, most of the time parents say, "Tondani noko shwas gyu, nakani shwas ge," and the same conducted sound goes inside, and we may diagnose as a wheezing per se. But mind it, always tell this patient to breathe through the mouth. Whenever the child is more than 6 years and above, better to ask them at least once examination should be on open mouth breathing. Skin prick test, so flexible nasal endoscopy showed enlarged adenoid pad in the nasopharynx. Skin prick tests were positive for house dust mite and Burch pollen. FE was dropped down. So we know the diagnosis of allergic rhinitis with enlarged adenoids. So with this, now you have a picture that this, as I said, it's like a ghost diagnosis. It is there in the background. As a pediatrician, as a physician, we need to find out and treat these cases because this is on rising. So what is going to be my talk? Like history, burden of allergic disease, what will be the pathophysiology, atopic march, allergic rhinitis, because implication means what happens to the child with allergic rhinitis if he is having allergic rhinitis. And diagnosis of allergy and pharmacotherapy, everybody knows, but I am going to little bit press on the other aspects also. So as allergies definition, everybody knows it's so I tell my patient very simple language, it's a nonsense response to nonsense thing, that's all. So allergies response to body's immune system, which is harmless substances. So what happens when first contact of allergen comes, the allergens get engulfed by the macrophages. These macrophages takes the allergen out of the surface and it gets attached to the T lymphocyte. So main orchestrating cell is not Ig, but it's a T lymphocyte which causes all the allergic cascade. So we think Ig is the main important. No, it's the T lymphocyte. How? You can see in the diagram. The T lymphocyte gets attached to the B lymphocyte in contact, and then they form the plasma cell. This plasma cell gets converted itself into plasma cells, and then this plasma cell produces a lot of specific Ig to that particular allergen, and these particular allergens binds to the mast cells, and they gets ready for the future attack from the same allergen. So if suppose there is a same allergen comes into contact in future, what happens? There is a degranulation of mast cells, and you see there is a lot of atopic dermatitis, eczema, allergic rhinitis, and asthma. A lot of time what happens when we are in OPD, busy OPD, we say, "Are hala atopia hai, hala hai." So we tend to get confused in atopy and allergy. So atopy is nothing but the tendency, the family tendency or genetic. So I would say allergy is nothing but the phenotype, and the atopy is nothing but the genotype. So you can say if mom and dad both not allergic, almost 5 to 15% chances. One sibling allergic, 20 to 40%. Both are allergic, 20 to 40. Mom and dad both are allergic, almost 60 to 80%. These are the clinical pictures of allergy all over the places: nose, eyes, skin, gastrointestinal tract, and bronchi, obviously. This is important, 3 concept of allergy. So it's like an allergic mass. When you see the child in a newborn period or in infancy, if this child is having atopic dermatitis, think about it. Just put that word that we have to control this vigorously. Otherwise, this may go and progress into atopic march like allergic rhinitis and asthma. There is something called polysensitization also. What is polysensitization? It is nothing but not one, but there may be numerous other allergens also which can be causing this issue. And obviously, there is a cross reactivity with so many other things. So I'm not going into detail of this. So this atopic march, usually it starts with eczema, then food allergy as early as possible, seasonal allergies and asthma. This is nothing but the game of Th1 to Th2 paradigm, because more allergic, it is a Th2 pathway. Usually eczema outgrow, some eczema almost 70%. Food allergy is almost 80%, but now I am seeing the change in trend. I have some patient, the food allergies, they are not going at all. Maybe the environmental change, sleep pattern, food habits, everything. So basically it's nothing but the immunological reactions, the inflammation which is setting inside the child's body. So allergic asthma is often first step of allergy marks. 80% of asthmatic patients have allergic rhinitis. This point is very important for you. So this is the famous diagram you must have seen in a lot of lectures, that it starts with atopic dermatitis, then food allergy, then asthma, and along with that allergic rhinitis, which goes on and on. This is very important again, because if you know there is eczema, if you do any early intervention, we will prevent the rhinitis. If you integrate the treatment with allergic progression, then you can stop progress to asthma. Burden of allergy, it's a global pandemic. I would say it's not pandemic, it's there always, and it's a global health issues. Almost 20 to 40% in all over the world. Even in now the Western countries, the developed countries are showing the plateau, but now in India it is increasing. So respiratory allergies are same. Last 2 years you must have seen a lot of increase, and skin allergies are increasing, food allergies are increasing. So good time for allergist. So 20 to 30% of population suffers from at least one allergic in India. Almost 40 crores in India. Almost 300 to 400 million Indians are allergic to something. Most of them are allergic to something. Maybe not necessarily allergic to allergen. They can be allergic to some other things also. So you can see the allergic rhinitis is increasing. The asthma is increasing. And burden of allergy, as I said, it's increasing. Now comes to the why it is important to know that allergic rhinitis, because this allergic rhinitis can goes into bronchial hyperactivity and cause asthma. So in this study which has shown that there is almost 4% increase those who are having allergic rhinitis, there is an increase in bronchial hyperactivity we call as hyperreactive airway disease, or something called as asthma. So allergic rhinitis classification, this is the classification which is going on from long time. you don't have time to ask these questions. You just have to ask whether how many days per week and persistent, or I ask how many days in a month. So in a 30 days, how many days your child is suffering from? Either of, so there are 4 types of presentation. Either you are blocker, either you are runner, either you are sneezer, or either you are eacher. So either of these, yes, your diagnosis is there. Then mild, moderate, I don't think they can go into mild to moderate. They can go from moderate to severe, and they can come back to mild also. So it depends on the different geographical area, the food habit, the sleep habit, everything. These are the some features like transverse crease, allergic salute, which is commonly not noticed by parents, and of course Denny Morgan's lines, allergic shyness. This is the ways very, very important. So all of you know how to diagnose the but my focus will be on this. So if you don't treat allergic rhinitis, you are going to have asthma almost 50 to 60%. If you have allergic rhinitis, the atopic eczema or atopic dermatitis is going to increase. I have n number of patients who are having severe allergic rhinoconjunctivitis, and nowadays because of pollution, there is so much increase in sinusitis patient because of, we don't see that many of polyposis, but we are seeing upper respiratory infection. We call not infection, the new terminology is called as upper airway cough syndrome. So child will be coughing, coughing, coughing. We give asthma medication, child is not improving. Go back and find out what is happening in the nose. The upper airway is very important. Last 2 years, I have seen almost 80% of patients in my OPD of upper airway cough syndrome rather than asthma. And of course, otitis media, because of early antibiotic uses, but it is there in silent mode. So you have to ask whether there is itching in the ear or there is a frequent sound like throat clearing, this type of, or some, they will be continuously honking cough, and it's common. So upper airway cough syndrome is very common. I would not say polyposis, but definitely these children have adenoids enlargement. It's again immunological part. So decreased quality of life because child is not sleeping. Sleeping disorder lot because we do I do sleep studies in Mumbai. I have the first center in allergic sleep study along with my friend Dr. Manisha Zuekar. So we do lot of sleep disorder patient. Learning and attention impairment is very much there because of these mouth breathing and dental malocclusion. So we had, I have a group called PAPA, Pediatric Allergy and Pediatric Allergy and Pulmonology Association in Mumbai. Me, Dr. Parma Chandre, and Dr. Manisha Zuekar, and he will be now member. So I have formed this 5-7 years back to help the kids who require this, through which we have done. So I am attached to Sion Hospital as a honorary. So we have done this sleep CME one-day program last year in October. So good response because of lot of increasing issues with the sleep because of allergic rhinitis and asthma also. So let's see how it coexists together. So as we know that one disease, there are so many evidence to substantiate their linkage. I will not go in detail of these. So because all of you know that the ciliated pseudostratified columnar epithelium which lines, obviously the vasculature of terminate. Yes, another one important thing I wanted to highlight now, last 4-5 months, I didn't know that, but I learned from my ENT colleague. These 10 to 15 years kid, they are coming with sigh of breath. रात्री डॉक्टर झोपायला त्रास होतो मुलांना, कारण ते ना असा श्वास घेते, मग हॉस्पिटलमध्ये जातो, वाफ देतात, जरा बरं वाटतं. This is not asthma. Asthma cannot be without cough. If there is a bronchospasm, so we have to look for something like there is a breathe. नाही डॉक्टर इथे कसं तरी होतं, मला इथे कधीतरी असं होतं. And this is very common in age group of that adolescent age group. The another reason which I found, these inferior turbinates are like your clitoris or your penile muscles. They get hypertrophied during that period of time. No need to put them nasal spray in this patient. So we have to just put the nasal simple saline spray, that is, I won't say the name, but hypotonic saline spray which comes sol spray. So we can use that and these children get better. You don't have to put, but along with that I teach them box breathing, and I teach them the 2 inhalation breath also, because to calm that anxiety. It comes with anxiety. Last week only I saw one patient from Kalyan, this girl, 13-year-old, from doctor's family, and she was like, so, मग हे ब्रिदिंग एक्सरसाइज कशाला करायचे, मी किती करू, मला पंप पाहिजेच, नाही पंप घेतला तर मला कसं तरी होणार, तुम्ही मला हे नका, मला पंपच द्या. But when I did the PFT, so PFT is very important, it was normal study. I told her no need to take puff. I explained her, I asked her, nobody want to, invest time in breathing exercises and all these issues. They want immediate. But one puff, she is all right. So it's what? Anxiety, psychological. As I said, it correlates a lot. There are a lot of studies which shows that rhinitis as a risk factor for asthma. So this also shows there is done n number of studies. I won't go in details. Allergic rhinitis increases the requirement of asthma medication. Without rhinitis, reduces the quality of life in asthma, definitely. So how do you diagnose? So diagnosis is very important to avoid the allergens, and of course the allergen immunotherapy, which is coming in a big way. Early detection is important for avoidance, immunotherapy, and symptomatic management. There are a number of tests. I think there is one lab from Ahmedabad. They are sending letters to everybody in everybody's clinic that we do allergy panel for 7,000 or 8,000. Please don't do that. It's a skin prick test or it's a specific IG test, which is, but skin prick test is the easily available and less expensive as compared to, but it has to be done with the expert. How do you choose? So it depends. So if you see all the guidelines all over the world, what they say, the skin prick is the first choice. It's the gold standard test. There is another test called in vitro test, that is serum IG. What it differs? So skin prick test measures the reactivity of mast cell bound IG, and this test, this serum specific IG testing does not measure the bound IG but only circulating IG, and we are not concerned with that. So this is the skin prick test, which is easily available and can be doable from 2 years of age. What is the best method? As I already said, there is a new kid on the block called Alex. I am doing this last one year. I have done more than 100 patients. So this is called as component resolved diagnostics from German. Alex, this is the Explorer. It's a very easy, it's a molecular. So we are not talking about you have milk allergy. Now I am talking about milk. What allergies this child is having from milk, whether it is albumin or whether it is casein protein. So we know that if it is casein protein, it's a heat resistant. This child is not going to get better all over the life. So I can tell them no need to try also. So this is called as molecular test, available, not easily available. I started 1 year back in my clinic. This is how the chip looks like, and this is how the report looks like. So once you know the report, we can go and see what are the, to the molecular level, where exactly is the problem. If it is dust mite, whether it is DERP1 or DERP2, whether it is a cockroach, whether it is a peanut, what type of RIH or H8 or 9. From that we can tell directly whether you will be able to consume or not. So how do you manage these patients? So most important is education, and education is very important. Pioneer, every time they come, we have to educate them. Allergen and irritant avoidance, pharmacotherapy is very little. Everybody knows what to put, what not to put. Immunotherapy is a specialist prescription, and monitoring follow-up is very important, because once they are all right, they feel now it's better, stop it. But we have to instill them that this is going to be a lifetime problem. It might be come and go, but you have to come and show once in a while to your doctor. So education, as I said, very important. Pharmacotherapy, very important, is the safety and efficacy. There are n numbers of drugs. We should not use whatever available to you, which is suitable to that patient. So patient teaches you. Some patient gets better with Montelukast, some patient with just nasal spray, some patient with Montelukast with nasal spray. So it's all, that's why we call it as a practice. There is nothing like only nasal spray works. No, we have to make sure what is the type of patient is. And of course, there are these medication available. I will not go into, but main important highlighted point is never use first generation antihistaminic They are not recommended. They are very much sedative, impaired cognitive function and anticholinergic effect. Even we have availability of nasal, in a infant, we have a lot of drops, CPM with pseudoephedrine combination, CPM combination. Please do not use. Ask them to, do the nasal cleaning. Second generation oral antihistaminics, they are the best effective treatment with persistent or intermittent, depend on nasal decongestant, dangerous if you use too much, but now they are coming with moisturizer effect, so that there should not be the effect of medicamentosa. And intranasal steroids. So all of us know that this is the main cornerstone of treatment for intranasal corticosteroid. If you treat nose, most of the time even asthma gets better. They have efficacy lasting for 12 to 24 hours, depend on the, and the most beautiful thing is, if you use it for nasal spray, the allergic rhinitis gets control, along with that your conjunctivitis gets control, along with that your ear symptoms also gets control. So this is the way you have to put the spray, not the straight. If it goes in your throat, that means you are not putting it properly. If it is coming out, that means you are not putting it properly. So so most of the doctors don't tell how to put the nasal spray. That is very, very important. And treatment allergic rhinitis, either you can start from here or start from here. It depends on your choice. So I hit hard because patient comes to me, must be tried so many times. So I hit hard and make sure that child gets control as early as possible to win the confidence of my patient. But it depends on every individual. It's not like hard and fast rule. So if you see, there are so many things in market. We have mainly fluticasone and mometasone. Furoate is better because it has got less bioavailability in the blood. So, and can be used about 2 years also, but mometasone works wonder if you have adenoidal hypertrophy also. And that has been done. Montelukast, I think every conference we talk about Montelukast. So I will not go in too much detail about Montelukast. This is add-on drug, not the first line of drug. So if you want to try practical, I speak only practical point. If you want to try, you try for some time. After that, you tell them to gain the confidence. Yes, your child is having allergic rhinitis, but this is not a medication. हे औषध संपूर्ण शरीरात जाते, नको तिथे जाते, हानिकारक होऊ शकतं. आपण असं करूया, जिथे त्रास आहे तिथेच देऊया. Then you can go back to your intranasal corticosteroid. Anti-IgE treatment is a specialist domain. I have used omalizumab not for allergic rhinitis, but I have used for severe asthma and severe urticaria. So this is the available from 6 months. Depemokimab will be available from next year. It is there available in the grey market. The cost is 60 to 70,000 rupees per shot, and that has to be taken for longer period of time. There are patients who are ready to take, they get it, and we give it. The most important is the game changer is going to be allergic specific immunotherapy. So if you do allergic immunotherapy, it's life changing. So I have data, even Dr. Sainath have got data that it has shown those patients who are going for every month hospital visits, after giving immunotherapy for these patients, their hospital visits have come down, their recurrence of symptoms have come down, and their quality of life has improved a lot, because we get immunotherapy from abroad, because in Dubai, I have patients from Dubai also, so they have easily availability of drugs. So now the new allergen immunotherapy tablets are available, which cost 1,000 rupees per tablet, and it's going to be available very soon in India also. You just give them, and if after a few years, maybe it will be available easily in the in a pharmacy also. So as I said, it's effective and indicated in moderate to severe AR, mild to moderate persistent. So most of the time, what happens? We try a lot of things, and then the patient comes to us, sir, आता काहीतरी ते मी ऐकलं immunotherapy आहे, ते आपण करूया का? But mind it, when it is too late, it is too late. We can't do anything. It's like that. So it is better if we intervene early. There are good chances of recovery, and but definitely immunotherapy, I would say it is not 100%, but it is 90% for 50% of my patient. It is 70 to 80% for remaining 30% of patient, and remaining 20% gets better, but they get 30 to 40. It's like a COVID vaccine. And not everybody got better with COVID vaccine. Some got disease, some doesn't got. So some patient of mine on immunotherapy day, they have developed the severe reactions also. So we have to come down on the medication. So it's like, it's a different science altogether. Duration of treatment is very important. Like एक साल लिया और फिर बंद कर दिया, not going to happen. It has to be minimum 3 years to 5 years, recommended after 5 years of age. Now we can give. So what actually happens? So it goes and acts on that level, immunology level, that Th2 gets converted to Th1, that is your main pathway for your infection. It produces the interferon gamma, prevents interleukin 4, and stimulates the T regulatory cells, and produces interleukin 10, which is responsible for IgG4, that is blocking antibodies to prevent the allergic reaction. There are two therapy. One is SLIT and one is SCIT. SCIT is not patient friendly. For adult patient, yes, but for pediatric patient, we usually use sublingual immunotherapy, and it's a doable. Local reaction, hardly I have seen. SLIT preferred due to safety, rare cases of anaphylaxis till date and 25 years. Compliance is big with the SLIT because after 1 year, if they are better, they stop treatment. So I am on time. The burden of allergies is immense globally as well as in India. We need better management of allergic disease, which can be enhanced appropriate diagnosis of allergies. SPT is a preferred diagnostic method for IG allergic mediator hypersensitivity. In vitro test may be utilized in cases where SPT cannot be done. Non-standardized extract have large variability in their biological effect or have lower quality as compared to the standardized extract. Standardized extract produce reproducible skin prick responses with high precision. Thank you so much. A healthy breath will always bring healthy life. Each one, teach one, and plant one tree. Thank you so much.
Thank you very much, sir. Any questions from the crowd? There is one question, Tushar, sir.
Yes, sir.
Is there a difference in frequency of use, as in daily BD versus OD?
Again, so it depends. So usually it's said that for pediatric patient it's a OD dose for both of them because the flow rate is the better because bioavailability is less. But sometimes I use twice a day. I'll tell you the reason behind it practically. Sometimes children may not take properly. So you have written one dose. Sir, रात्रीचा घेतच नाही dose. At least एक dose सकाळी तरी जाईल. So that is practicality. Okay. So, but usually it is a single dose, and depends. Like after 12 years of age, you can use BD also, or after 6 years also you can do BD. That is, study-wise proven. But in pediatric patient, it's a OD dose. But again, I said depends on your patient to patient. If your patient is very much, easily. And is ready to take your nasal spray properly, then so OD dose is more than enough because it works for more than 18 to 24 hours. That's right.
Sir, nasal spray, how many days afterwards?
So there is no nothing like you have to give for 1 month or 2 months. Basically, the first study which has done, it has shown that minimum for 3 months. But you can give for longer period of time. So I give honeymoon period in between. So I call it honeymoon period. Stop for 1 month or something when the environment is good. So last 2 months I stop for lot of patient, and then again because now rainy weather they will go to school. I again restart it. So it's depend on your patient to patient and what allergies he is suffering from. Suppose it's a dust mite allergy, it is going to be there for year around. So it's better to keep for longer period of time.
Thank you, sir. It was a vast topic, but within 30 minutes, sir has given an excellent account of allergic rhinitis.
Thank you, sir, for that interesting lecture. I request the speaker and chairpersons to proceed for felicitation. Moving towards our next topic, another important one pertaining to daily practice, fever treatment back to basics. May I call upon Dr. Narendra Naniwadekar sir to guide us for the same. To chair the session, I invite Dr. Ashok Choghule sir, Associate Professor Pediatrics, Prakash Institute of Medical Sciences, and Dr. Amol Mohite, eminent practicing pediatrician of the town. I request the delegates during the breakfast and lunch session kindly visit the stalls as well.
Good morning everyone, and at the outset let me thank the organizers for having invited me for this talk. We are going to talk about absolute basics, fever treatment. This is something which we are dealing with day in and day out, and the veteran practitioners might think or might feel that there are few things which are boring, but still we have to go through that. And there are PGs which are going to maybe get some carry-home messages. So fever, no other emergency makes the parents panic more than the fever, barring of course the convulsions or seizure. The anxiety is transferred directly to the treating healthcare provider also. And smaller the child, more is the pressure. So when we talk about fever, I always remember we have a maverick called Dr. Rajesh Chokhani, who had given us a beautiful limerick. I'll just try to modify it a bit. The moms get hot because her tiny tot is suffering a lot. Papa gets hot because there is no more on his mind, but complain he dare not. Dog gets hot because he is pulled out from his cot, or diagnostically it finds him in a tight spot. And pharma gets hot because their cells are in top slot. So fever is our daily bread and butter. Maybe after a few years the allergies is going to be a part of it. So it's nothing but elevation of body temperature that exceeds the normal daily variation, occurs in conjunction with an increase in the hypothalamic set point. This is the theoretical part of it. And what is important is with every degree of rise, there is going to be increase in the oxygen consumption. The child is going to feel irritable, and every time you will be brought up with a high grade fever child, the parents are anxious. So this is a every time story. Even if you treat fever for so many years, we know that every time a child comes with a fresh set of fever or with a fresh set of infection, the anxiety is going to be the same at every level. So the question is whether the fever is a friend or a foe. Basically, we have to remember that it is, whenever there is fever, it is trying to, the raised temperature is trying to control the disease process, one, and it's the sign which is telling us that everything is not right in the body and prompts us to look into the underlying cause. It's like a machine which has gone wrong, and the fever is like an alarm. All we do is to shut down that alarm. That we'll see how we treat that. The most important thing is that it makes the child uncomfortable and increases the metabolic needs of the body, and is the messenger that brings you notification that the body is responding to that insult. And all of us know majority of the times this insult is, the fever is because of the infection, because it's the inflammation which is going to bring up the fever majority of the times. There are few cases where the inflammation is not the reason, but those are more rare. Commonly what we see is the insult to the body has responded in view of inflammation, and that insult may not be infection always. It may be some autoimmune disorder or some other things like malignancy, which is giving us the fever. But it just tells you that something is not right. So for me, it is more a friend than a foe, because it is helping us to detect something, and it is helping the body also to fight the disease. So how do I approach the fever? Of course, over here again, there are people who are going to say, fever mein usme bada kya cheez hai? But what makes you worry and what tells you what kind of fever the child is facing? So I will ask myself absolute basic questions, or I'll ask the parents absolute basic questions. First, how is the onset of the fever? how did the fever begin, whether it began as a small, low-grade fever or it came as an explosive high-grade fever. What is the response to paracetamol, whether the fever is responding to paracetamol or not. How is the interfebrile period behavior? And this is very important, because if we see 100 patients of our OPD, if we see those who come with viral fever, the parents will always say ki हाँ ताप उतरला की तो खेतो. Then the parents are okay, but ताप चढ़ला ki even the parents become hyper. All of us know this. And how this fever has progressed by the day 3 or by day 4, because that is the time when you come to know a simple viral infection would usually come down or will start showing some trend that this child is improving. A child who has got bacterial fever, maybe something else, the child may show signs of worsening, which tells you that something is not happening good to this child. Then by that time, the localizing symptoms may also come. A child who comes with high-grade fever, 3rd, 4th day, the child is complaining of sore throat, child has got a painful tonsils, then you know probably where the infection is. A typical bacterial infection where localization will take some time to happen. And of course, the contact history, this is very important, especially in upcoming season of dengue, when we have got rickettsial fevers, when we have got other contact with the child. Of course, malaria is not rather it's not seen in Kolhapur vicinity. I am told that even in Mumbai, malaria has gone down a fair bit. So all this is giving us an idea as to what this child is likely to be suffering from. So the basic approach is, after we have taken the history, take an ABCDE approach, never forget the ALS algorithm, because I want to know whether it's a stable child or a sick child. A child who is howling and child is crying, it's difficult for you, 2 or 3 of you, to hold the child just to examine, and the child is otherwise comfortable in the mother's lap, is a stable child, most probably will not have to worry about it. But in case the child is listless, the child is not having an eye contact, even after the fever goes down, the child is sick, that tells me that probably this requires more intervention, more attention, and this child is likely to progress to something sinister. And of course, all of us know 80% of the time these are simple viral infections. So there are signs where I am going to worry a bit. So which are the things? First is a child who is younger than 3 months old. Of course, a child who is less than 3 years old, I'll always be worried. Even if the child is playing active, I'll be keeping a close eye on the child. And apart from that, in case the child has got any of the followings, has either extreme lethargy, drowsiness, excessive cry or irritability, vomiting everything and not able to accept feeds orally, headache, neck stiffness, abnormal behavior, this is very important, and temperature above 104, and the fever which is persisting for more than 5 days. All these tell me that I should be worrying about this fever. And especially the behavior part is very important. This tells you this child is out of proportion, abnormally behaving, so this is something not good. Either the perfusion is not good, or there is hypoxia, or the brain is irritable. So something sinister is happening. But when am I at ease? If the child is playful and active during interfebrile period, I am comfortable. If he is acting like himself or herself, he is doing fine, otherwise there is no problem, then I am not worried. He is feeding well. That also gives me a sign that, of course, we don't have to worry about it. If he is passing adequate amount of urine, just telling me the sign that the child is well perfused and is well hydrated. Then comes really, how do I measure the fever? This is something which we take it for granted कि हाँ बुखार है मैंने देख लिया है. So there are multiple ways where we are going to see. There are digital thermometers, which are the in thing, which is the thing which we need to carry on. Plus we have got these tympanic thermometers, temporal artery thermometers, infrareds. We'll just go quickly through them because this is more of a theory rather than what is practical. Tactile assessment, our standard. बाळाचं डोकं गरम झालेलं आहे, बाळाला ताप आहे, and the child is active and playful, you know that this is not the case. The head is always going to be warmer simply because the blood supply is good, and the child is always going to feel warm in the head. That does not mean that we are having fever. So it is overestimating of skin temperature, cannot be used for follow-up in febrile patients. and it can unnecessarily bring the child to the healthcare facility. So correct assessment is required for a precise temperature measurement, and the skin surface thermometers are not accurate, influenced by all the environmental conditions. The outside cold is going to work on them. So what should be an ideal thermometer? It should reflect the core temperature. It should really give an idea about core temperature. It should be easy, safe, comfortable to use and give rapid results, and should not be influenced by room temperature. And this is the requirement of an ideal thermometer, and ideal things do not exist in life. So no ideal method or thermometer is been available which will fulfill all the above criteria. But just to go through them, most important is that important to see the trend of the fever. If you have chosen one thermometer, just follow that and see how the trend of the fever, whether the child is doing fine or the child is improving or the temperature is rising, what is the exact trend happening. So you can use a sublingual, mouth should be sealed with tongue depressed for 3 to 4 minutes, difficult for task for children. Of course, mercury thermometers are now out for the fear of in case they are broken, if there is a mercury poisoning, you had it. Digital thermometers are recommended. Accuracy lies somewhere between that of axillary and rectal, not below 5 years because the child may not keep it in the mouth. And this is the area where the child is going to have maximum incidences of fever. It will be influenced by ingestion of food or drink. You may be remembering one of the cartoons where the hot tea, the child puts the thermometer and then puts in, the father feels his child is running fever. Then the axillary, which is the commonest one, which is used directly over the axillary artery for more than 3 minutes, largely influenced by environmental conditions, but despite its low sensitivity and specificity, is the recommended as screening test for fever. Then tympanic membrane. This is something which is coming up. The theory is that it is an ideal location for core temperature estimation because the hypothalamus blood supply and the TM's blood supply is supposedly similar in appearance. And crying otitis earwax does not change the readings significantly. It is likely to become gold standard for children. The rectal thermometer thing which parents may not like, at times this will be used, traditionally considered as a gold standard, specially used for newborns and small children affected by presence of stool, and rectal perforation rarely has been described. Then your temporal artery thermometer reads infrared heat waves, can be used in 3 months and older children. Temperature should be taken on the side of the forehead. It's a promising tool for screening children at low risk at hospitals. Cannot be recommended for home or hospital when definitive measurements are required. An infrared measures thermometer rapidly and non-invasively. There is a poor accuracy, not recommended. We already said that. It's used for mass screening. You must have seen during COVID, you went to airports and this was done. I don't know whether it satisfied them or satisfied us. We really do not know. So recommended temperature techniques are for age, birth to 2 years, rectal definitive, axillary screening, 2 to 5 years rectal, tympanic, axillary, older than 5 years oral, tympanic, and then axillary. These are the recommendations which are followed. Now, why do I treat the fever? That is the most important thing. Most of all, it's not the fever, it's the discomfort which the child is having. Discomfort of the child as well as discomfort of the parents, which we need to treat. So it is to increase the comfort of the patient. The moment the basal metabolic rate comes down, the child starts feeling better. Ensure that the patient is getting adequate sleep. All of us also know when you are running viral fever at night, when you are running fever, you don't sleep. You just turn topsy and turvy in your bed. The moment the fever comes down, you get a sound sleep. And it will lessen the irritability and improve the behavior of the child. The moment the child's behavior improves, the parent's behavior also improves. And most important is, this will buy me some time to investigate and diagnose the underlying problems. So you take care of the fever for the time being, see how the fever is trending, and then you come to know what is the next step. Are there any localizing signs coming up? Are there new symptoms which are coming up? Which gives you a clue to the diagnosis. So you treat the patients with symptomatic antipyretics, paracetamol, brufen, query aspirin, we'll see each one of. Supportive treatment, tepid sponging fluid, wards, clean, cool and calmly. Specific is doing the investigations, either do cultures, counts and antibiotics only after the confirmation of diagnosis or empirically in case the child is extremely sick. So what are the common misconceptions? When we are treating the fever, the parents also have few misconceptions. Even few of us will carry those. First is concerned with need to maintain a normal temperature. We always try to tell the parents, I am not running after to bring that magic figure of 97 to your child. Even at 102, in case the child is irritable, on day 1 or day 2, if the child's fever comes down to 100 and at that 100, the child is feeling comfortable, then I think we have done the job. That is what is expected. I don't expect this child's fever to touch to 97 on day 1 or day 2. So far the child's behavior is fine, I'm okay with it. And there is a misconception of administering antipyretics even at minimal or no fever. Doctor त्याला 99 तापी मी त्याला औषध देऊ का? Over here we have to keep one thing in mind, that whenever there is a fever, there is an insult to the body, the hypothalamic set point, whatever cytokines are released, are going to decide अभी उसका बुखार 102 तक लेके जाने का है. And the moment you give the paracetamol at or whatever antibiotic at 100, at 99 you give it, but the set temperature was decided to be or destined to be 102. Despite giving the antipyretics, the child is going to reach that figure of 102. मग औषध दिलं तर त्याचा ताप वाढला, मग मी आता काय करू? And then the other things start coming up. So that is very important. Approximately 50% of the parents think that 100 के आगे बुखार है, 25% give antibiotics at 100 degrees itself. Some parents awaken this child, है झोपेचं औषध द्यायचं, उठा आणि झोपेची गोळी त्याला देऊन टाका. It's like that. And majority of them give wrong doses of antibiotics. So we have to know that the dose is to be given as per the weight, and we have had fights with educated parents. Doctor त्याला 5 ml द्यायचं औषध. We have to tell them this child's weight is 16 kg, the dose is 15 mg per kg, so correct dose is 5 ml, so give 5 ml. So you have to convince them that a right dose is to be given in order to achieve whatever desired result is. So then we have got other ways of treating. Environmental modification, clothing, air conditioners. The patient shouldn't be wrapped too much, loosen the clothing. Cotton clothing preferred over synthetic. Overclothing itself is going to cause fever in infants. Place the child in a cool, airy room with minimal clothing. That should not give him shivering, because this will be exactly doing the reverse of what we want to do. The AC, we know the summers are becoming more and more hotter, and AC can be used in extreme hot weather. Too cold may cause vasoconstriction. The ideal best would be to maintain the temperature between 25 to 26 degrees, where the parents and the child both feel comfortable. And non-pharmacological management, fluid intake. We all know high temperature increases insensible water losses. Give adequate fluids. Watch for urine output and color to decide the fluid requirement. It should pass a light colored urine every 3 to 4 hours. And use IV fluids in case oral fluids are not tolerated. But keeping in mind, while putting in IV, we should not give rise to chills and rigors, because again it is going to cause more harm than good. Then tepid sponging, this is where the controversies would be. The recommendations are, it may be done by continuous wiping of the body with tepid water. Gaar pani ni pusu ka. Gaar pani itself is going to give stimulus to the child's skin, that there is a cold outside and the child is likely to have shiver. So again, causing exactly the reverse of what we want to achieve. It ensures that the water film is constantly moving, thus maximizing the heat conduction. But it is shown that hydrotherapy alone is clearly inferior for reduction of fever. For more than 30 minutes, it may not be used. It will just help the antipyretics in case it is required, if it is helping us. The bathing with tepid water during fever may bring down the fever, but young infants should not be kept exposed for a longer time. Then comes the pharmacological management. All of us know, but still, let's visit it. Most commonly and most standardly used drug, paracetamol. Ibuprofen is sparingly used with caution. Mefenamic acid and nimesulide is not recommended, as it can cause hepatic toxicity. And all of us must be seeing at least 1 or 2 patients coming with hematuria, those who have taken mefenamic acid as an antipyretic. Aspirin is of course contraindicated in children below 12 years as antipyretic because of the risk of Ray's syndrome. and combination of antipyretics like with paracetamol, with brufen and mefenamic acid are not scientific and unsafe. Probably in the lunch, after the lunch, we'll learn more about it. So, paracetamol is safe in children, less side effects and ease of administration. We should not forget that we don't use 10 mg per kg dose, we use 15 mg per kg, maximum dose of 60 mg per kg. And the paracetamol has got an advantage simply because it has got a very wide therapeutic window. In case somebody takes one extra dose, it's not going to cause harm because the toxicity of paracetamol will happen beyond 100 mg per kg per day. It has got a short duration, can be repeated after minimum 4 hours, and this is exactly what we have to counsel the parents. डॉक्टर त्याला मगाशी सकाळी 8 वाजता औषध घातलं होतं आणि आता पुन्हा ताप आला 2 वाजता. It has to come. The fever is telling you that something is wrong. The action is already over. All you have to do is keep on giving paracetamol. That does not indicate that we have to do something different. And of course, we have got availability. All of us know we have been using this drug for a long time. The only problem and the caution is misinterpretation. And if you see, tala Calpol dilala hai. Let us not take the names, but he has been given. So we have to ask, what medicine is he taking? Is he taking drops and is he taking the syrup? Imagine the drops 100 mg per ml are used and you tell them that the child requires 2 ml, thinking that this child is a small child, they have got a syrup. So you have to always ensure what do they have. Fortunately, with mobiles and other things in your home, or you can keep a bottle of Calpol drops, or the paracetamol drops and paracetamol syrup, whether this bottle is with you or the other bottle is with you, because in case the child consumes higher dose, it is going to be risky. And this is a practical problem which I think all of us must be facing. It can be used as a suppository also, if the child, in case the child is vomiting. The only thing is appropriate placing is important. Too low will fall off, too high may cause injury. The older one may be scared of introducing the suppository, and in hot environment like any other suppository, they are likely to melt and needs refrigeration. The dose is of course the same, but since the absorption is erratic, a loading dose of 30 mg per kg may be used. Then comes the most loved question, role of antibiotics in fever. For this, I'll just give you 3 case scenarios. One is 4-year-old male child, high-grade fever, interfebrile period, normal, no localization. Put on amoxiclav, paracetamol. Second, 3-year-old male, high-grade female, high-grade fever, no localization and headache. Put on azithromycin, PCM, mefenamic acid. 8-year-old male, fever, high-grade, put on cefixime and paracetamol. This is day 1 scenario. What is the scenario on day 3? The first child with high-grade fever, no localization, developed pleomorphic rash. It was varicella, so it was varicella from day 1 itself. Second child, no localization, developed flush extremities, NS1 positive, dengue. Third one, developed coryza, body ache, was H1N1 positive. So from day 1, the child was harboring the same infection. There was no role of antibiotic on day 1 of his fever. So antibiotics, just remind me of this. I have a fever, take ceftriaxone. Fever is not a sign of ceftriaxone deficiency, or for that matter, antibiotic deficiency. So carry home messages for the parents. Fever is friendly and helps fight infection. Any thermometer can be used to see the trend of the fever. The goal is to decrease the discomfort, not to bring the temperature to normal. High fever does not cause brain damage. Ensure good fluid intake during fever, and paracetamol is the safest drug for fever. Except for hyperpyrexia, which I have not tried to cover, I would rather worry for the cause of the fever than the fever itself. Thank you.
Thank you, Narendra. Really, you have gone into basics of the fever, management and the causes of fever. We talk so much about paracetamol, but still many of the pediatricians and even general practitioners are using for combinations, especially paracetamol and nimesulide. Recently, I lost one child because of mefenamic acid toxicity also. That when I was working in Diva Patil, I lost one child with mefenamic acid. So be careful when you're using these drugs. I think still the paracetamol is the drug of choice. And second thing you told about ceftriaxone, really it has become, I don't know, everybody for very small things ceftriaxone used. So we have to be very careful about using the antibiotics. Thank you, Darendra, for your beautiful lecture. Thank you.
Thank you, sir, for sharing those useful tips with us. I request the speaker and chairpersons to proceed for felicitation. Brings along with season of various infectious diseases. Our next topic is on the same. Pictorial journey in infectious diseases. I invite Dr. Tushar Maniyar sir to guide us through this journey. To chair the session, I call upon senior pediatricians Dr. Vichare sir and Dr. Sulbha Pawar madam.
Thank you. Thank you, and thank you very much for your invitation to the great city of Kolhapur. And this is my first time here, and I assure you that I would like to come here more often. I would want all of you to bring out your phones, scan the QR code which you will get over here. Believe me, there are no prizes or gifts from that QR code. Just a small warning. You will have to be answering questions. We are all compulsive examiners, but there are no marks here, okay? It's more like a poll. And today I'm going to talk on pictorial journey in infectious diseases. So I thought I have to include pictures, and it has to be a journey. So when we say journey, usually you go from one point to the other point. So in my presentation, we will try to take one symptom or a sign, and then we go on to the other, and we keep on adding them. And finally, when we talk about journey in infectious diseases, we will be talking about okay, can you scan this, please? And then you can click ready, so I know that you all are, or how many of you are logged into this. Can you scan this? Or otherwise, if you have Mentimeter, you can just write this 532106279. I don't have too many questions, I have only 5 of them, but we'll do it along. This is just so that I know that you are around, I'm not talking alone. Nowadays, we talk on this online mode, where we keep looking at ourselves and talk. Okay, so I see most of you have already scanned, and it will take a while to get it down. And you will get scans against in the questions also. So if you haven't, then it's fine. And I love this one when you say cannot do it, because that means you are already on it. Okay, so you have a child, we have been talking about fever. And you have a child with fever who is sick and no rash. And you can see this white membrane-like thing on the tonsil and on the uvula over there. Now this child also had a swelling. Why I'm pointing out is sometimes what I see on my screen may not be very easily visible to you. So you can see a swelling around the neck. And then you will wonder what are the options, right? So can you write the diagnosis or what comes to your mind? You have only one choice, and I'm sure nobody is going to be right or wrong. It's just a kind of a poll. So remember, you have this child who is sick, has a membrane and a neck which is swollen. Brilliant, see? Don't worry about the spell checks, capital, etc. Yeah, I'll wait for couple of more answers. Brilliant. So I have 3 answers here: diphtheria, tonsillitis, and EBV. Okay, and I have no personal choice for diphtheria. It's just that more number of people choose diphtheria, the word becomes bigger on the answer screen. And you are absolutely right. Tonsillitis, EBV, diphtheria, these 3 becomes common options and rest of them are less common. But now imagine you saw this also on examination, okay? Along with all this, you saw the child having nose discharge which is thick and mucoid. Now that will take me away from tonsillitis, that will take me away from EBV as well, and I'll be thinking more in terms of diphtheria. Brilliant. So that is why when we have this particular situation, we must keep in mind how to differentiate between the other close differentials. If you see this one, this child has a similar complaint, tonsillar swelling and a patch again on the tonsil. By the way, if this one doesn't look very Indian, it's because most of my images are taken from Red Atlas of Infectious Diseases. It's a wonderful book. If you want to go through the pictorial journey beyond 30 minutes, please go ahead and try that. Now if you see here, I have now included rash on this. So this child, even before giving medicine, or as Dr. Nanivadekar said, after giving a coamoxiclav or amoxicillin, developed this rash, and then you will start thinking more in terms of EBV versus diphtheria. This child also had a rash which was not like EBV. This child, you can't really appreciate very well, developed a facial rash with a perioral sparing. What is perioral sparing? Means there is a rash, but there is this area around the nose and around the mouth is spared. Okay, this is quite classical of a condition. Along with that, you did not see a white membrane, but you had this child coming with fever, throat pain, and this palatal petechiae, meaning the petechiae were on the palate, and you are thinking in terms of streptococcal infection or a scarlet fever, streptococcal throat infection, whatever. But imagine this child came with fever, throat pain, and had lesions not on the palate but way back on the throat. Then you would think in terms of a viral pharyngitis or some kind of a non-bacterial infection. Now we continue our journey. Now we talk about rash and fever. So now we say this child had a rash, tongue was red, and the eyes were also red. But contrary to the standard conjunctivitis, the eyes were not having any discharge. So, though we are talking infectious diseases, child doesn't come and say that I have today a class of infectious disease. So, we must keep our other options open. The other thing I would like you to notice is, just like we spoke about perioral sparing, you can have a perilimbal sparing here. Okay? So, just around the cornea, in a red eye which has no discharge, if there is sparing of that area, then it becomes even more suspicious of Kawasaki disease. Now this child also had a rash, but that rash started around the perianal or the genital area, and it's more like a polymorphous rash, so it can be having multiple type of picture. But the negative connotation is, if there was a vesicular rash or a bullous rash, then you are not thinking of Kawasaki disease and you will be thinking of something else. We are at conjunctivitis now, so we continue our journey. And this child also had fever, rash, and had red eyes. But this was more like what we call suffocation, meaning on the conjunctiva there was fullness and redness. And here you can see a slight tinge of icterus. Monsoon's coming and leptospirosis is not far away. So if you have a child who comes like this, then think about leptospirosis. The only catch here is the suffocation comes much early in the disease, whereas icterus comes in the second immune phase, but the suffocation may still be present. So we have now seen till now various situations where you have the patient who has come in acute and has followed up with you, and you have seen them and made a diagnosis. But many times you will have a child who comes like this, and then they will say, Tap hota, when you ask. We managed at home, nicely as we said, paracetamol was given. Whether they was given Dolo or Calpol is a matter of discussion. but it was given, right? So now what do you think about it? How do you make a diagnosis? What is the commonest condition that would give this rash? It's a bit of a trick question, that's why. So if you see in your common practice, most of the time, to be fair, the patient won't come to you. The commonest condition is post-prickly heat. When you get this kind of desquamation, they will come to you. But you are talking infectious diseases, right? So obviously you will say scarlet fever because it's a rough area and no particular predilection. Scarlet fever also you will see more in the flexure areas as well as this area. This child, of course, as they rightly said, is a child with history of scarlet fever. But if you see this kind of a rash and peeling, which is significant, then you will think in terms of a Kawasaki which has been missed or not come to you. And after a week or 10 days, you will see sloughing and periangual desquamation, which is quite significant. And then you have another child who says, my child also had fever and rash some time back, but all the nails are coming off. What are you thinking of? Any thoughts? So if you see only one nail affected, you can think about a local condition, but if you see all 10 nails, fingers and toes affected, this is post-HFMD, post-hand-foot-mouth disease. Not very common, but fairly you will see it not very rarely as well. The important thing is they will be very scared, but the nail comes back and comes back normal and not dystrophic. Okay? But if you see only the white lines, okay, like this, and not peeling, and the child had fever and rash, they are BU lines, and they are because of a temporary growth arrest, which can occur with hand, foot, mouth, but it can also occur in conditions like Kawasaki disease. Okay? So these are some of the pictures which some of them I have shown and some of them I have asked you to imagine. Now let's look at one more symptom. Like, your one journey or one vacation trip is over. We are now on to the next one. You have this young infant or maybe an old neonate, as I would call it, and you can see the baby has a temperature regulatory probe here and a reasonably sick looking child with pigmentation. What are your thoughts? Can you put it over here? Can you see can you write on this? You can say it loudly. Leaking answers in an exam paper is a politically sensitive discussion currently, so we will not get into that. Yeah, don't worry about the spelling. This autocorrect actually has not improved our English, it has only worsened our English because an AI has now become even worse. Now I don't bother to correct it also because it is too smart to correct. Excellent. So pellagra is a very interesting point. This is a very small child and I would not think. But tell me one more answer since this is on. If a newborn or a newborn first 1 week comes with hyperpigmentation, what is the thing that you want to rule out? Excellent. CAH. Brilliant. So when you see hyperpigmentation, chikungunya in young infants is very important and it's a good idea to ask family history. Usually somebody else in the family may also have suffered from chikungunya. And again, when you see hyperpigmentation in bigger children, why I have put this is obviously not an infectious disease, but a life-threatening disease and otherwise easily missed. So you will have a child who comes to your emergency with hyperpigmentation in collapse state, a big child with hypoglycemia. You do sugar thinking of DKA and you find hypoglycemia instead of hyperglycemia. Start thinking of Addison's. He may have only had vomiting and one admission prior for vomiting loose motions, was treated and became all right because somebody gave IV fluids with dextrose and not done a sugar before. This is another area I thought was very important to differentiate was ulcers. So what are the differential diagnoses of ulcers if you see in the mouth? Right? It's a fairly common condition and we all deal with this every now and then. So if you see an ulcer like this versus an ulcer like this, and the third picture that I showed you earlier. So the approach would be to ask few questions. Whether it is a first time or whether it is a recurrent ulcer, whether this is a painless ulcer or painful ulcer, and what is the distribution of ulcer. Finally, if you don't have answer from there, you will look at other sites in the body, and if you find this, then you are relieved that you are talking about a hand-foot-mouth disease. And when you say hand-foot-mouth, I think people got tired of adding the sites, because I would like to make a diagnosis. I always ask them knees, elbows and buttocks. If you get knee, elbows and buttocks, there are less differentials than hand, foot and mouth. So somebody should have come up with that abbreviation rather than this one. But we are talking about hand, foot and mouth. So suppose you saw this infant with this kind of a rash. What are your thoughts? Don't worry about the Mentimeter, you can shout it out. Okay, brilliant. Okay, so what do you do? Mother's hand, right? Or father's hand. Or nowadays more likely maid's hand. Depends on where you come from. No, in my practice, unfortunately, I see small babies being carried by the maid more often. And when I'm giving the injection, after giving the injection, the child gets calmed more easily and quickly in the maid's arm than the mother's arm, which actually bothers me a lot. And nothing against the mothers, okay? Fathers are not there in the room only. So before somebody comes on to me, let me be very clear. And since we are on that, we classically say that first visit of the child has 4 people along with them. Mother, maternal and paternal grandmother, and a maid, and probably a father. And as the child becomes bigger, the number of people who come along becomes lesser. Okay, so you have one more kid with an ulcer sitting over here. Also had loose motions, minimal fever, and this lesion. What are you thinking of? Herpangina, very good. So you can think about herpangina. But if you have this kind of ulcer which is painful versus this kind of which is painless, then you are thinking more in terms of painful ulcers are more likely in herpes, right? Especially the site which we have shown. If you see on mucocutaneous junction, if you see single ulcer versus multiple ulcers, if you see multiple ulcers, you see recurrent ulcers, then it's more likely to be herpes simplex rather than anything else. Painless ulcers, please remember, painless ulcers in female child, in teen or adolescent age group, think about SLE. Think about SLE, that may be your first sign and have time to intervene early, okay? I have given you the answers, so we will skip this one. Now you have seen this ulcer on the lip, okay? So we have seen that is like a vesicle, and we are talking about herpes. So herpes, since we are in a journey mode, we are connecting herpes with this kind of a lesion where you can see the midline cut off. So we are saying this is likely to be herpes zoster. And why do we say that? If you see a child with herpes zoster, it's uncommon but not impossible. But if you see a child with herpes zoster who has bilateral lesions, has a second episode of lesion, then please rule out immunodeficiency in them, either acquired because of some treatment or otherwise a congenital primary immunodeficiency. The timer is not seen? Good, timer is seen. Whereas this one is a more innocuous one, that is your varicella, and you can see this commonly in school-going children, and there are seasonal variations. Even after 2 doses of varicella vaccine, one can have breakthrough infections. The idea of giving the second vaccine probably is that they say 100%, so I'm going to quote, 100% prevents severe varicella. In medicine, I'm always very hesitant in saying 100%. But similarly, again, continuing your journey, if it was varicella in first trimester, one would get this kind of a problem. Whereas if you have varicella perinatally, just before the delivery or little after the delivery, then you can get such severe varicella, and that is why it's important to treat the mother urgently, as well as keep, if VZIG theoretically, but here we don't have, so use IVIG if needed, and of course you can use acyclovir. Just to enumerate, I had promised Dr. Vichara that there are not going to be more than 3 slides with words on it, since I am strictly restricting myself on pictures. So herpes, 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 but also not to forget staphylococcal scarlet skin syndrome. And typically these are not vesicular lesion, these are more likely to be bulbous lesion. It means the size is going to be bigger and the skin peels off very easily, called Nikolsky skin, and that is more common with this. But you can also have non-infectious. In bigger children, it could be insect bite. In neonates, if you have a similar lesion, think about epidermolysis. Okay? Now, this child has no fever, has this kind of a circular rash, and this is another kid who had a circular rash with central clearing, and after a few days, you are seeing multiple other lesions, and this guy is becoming bigger by the day. Okay? So let's see, what do you think of this one? What is the largest or the first lesion called? Hopefully you won't have to scan, you should be able to see the question on your Mentimeter, but otherwise you can scan again. Excellent. Okay. So, yeah. My question is slightly different, but I'll accept the answers all the same. So the largest lesion is called as the herald patch. Okay. It heralds the further rashes which come. Not important. Sometimes you hear these fancy names because I feel I should have told you something new than what you already know. So that's why I use these kind of pictures. But basically we are talking about this as pityriasis rosea. Now this is a self-limiting condition, looks very scary because there are many red spots, but they become all right and you don't need to worry about it. So what are when you see a circular rash, what do you think of? Obviously circular, you will first think of ringworm, which was the first image on the left side that we showed, and pityriasis rosea. Now we are on travel, right? So Lyme disease, it's more common in the US and some other European countries, and we won't be far away before we import some of them. Urticaria, psoriasis, and erythema multiforme are some of the other conditions which are non-infectious, but still a differential of circular rash. Okay? This is your area of expertise and not so much mine, so you know the answer. A 7-year-old child with fever for 6 days, history of high fever for 5 days, headache, and now hypotensive. The problem is, we will not examine these areas which are more common or more likely to see the bite mark. But if you see this, we are already late, unfortunately, and this is going to be like a sequelae. Similarly, this rash, one of the infection where the rash can come on the palm and the soles. So we already saw a scabies, we saw hand, foot, mouth, and we saw this rickettsial rash which can come on palm and soles. Very few rashes come on palm and soles. So that's why if you see something on the palm or the sole, you want to be careful. Okay? Now, as I said, we are on a pictorial journey. So we started with the conditions which were forever present. Then we are going to show you some re-emerging disease. So what is this? Anybody? Syphilis, right? Unfortunately, whatever happens in the US or the Western countries, we tend to get it back over here. And they had a major epidemic of syphilis and measles, and we are also seeing more cases of syphilis, and we had, at least in Mumbai, we had a major outbreak of measles last year, and even this year the surveillance is still on. The important thing to note is, newborns don't have cold. Newborn has cold, rule out choanal atresia first, that means nasal discharge, and second, try and think whether it fits over here. This differential here is probably of either a birth injury where the child will come as a excessive crying, hand will be swollen, and or otherwise you will think in terms of child abuse, which is now called as non-accidental injury. But actually this is because of periostitis, which you see over here in syphilis. Okay? So old wine, new bottle, measles, diphtheria, pertussis, scarlet, adenovirus. Adenovirus is something, I don't know the story in Kolhapur, but in Mumbai we had a major epidemic, even you all had, right? Of course. We are not too far. So how do you diagnose or suspect adenovirus? Adenovirus was a situation where you saw fever, rash, conjunctivitis or loose motions. Most of the children did not have loose motion as well as conjunctivitis, and the fever was unabated for 4 or 5 days. And the CRP used to, those of us who did CRPs, it used to come very high, and we were thinking in terms of, earlier we were thinking in terms of enteric, and then later on with molecular diagnosis, we are making more and more diagnosis of adenovirus. Many times parents ask कि करके फ़ायदा क्या है? आप बोल रहे हो दवा तो है नहीं उसका, तो क्यों करना है? The idea is, recently we did for one other patient, if your adenovirus comes positive, you can stop giving antibiotics, waiting for your cultures to come, or even after culture comes negative, you think of enteric fever or some other occult infection. If adeno comes positive and otherwise picture is fitting, you can reassure the parents and monitor the child. And I believe we are going to talk on, by Dr. Kore, we are having a full session on emerging and re-emerging disease, and I have just put these slides for pictorial depiction. All these 4 are various types of skin manifestations of COVID. Hopefully it's done and dusted and we won't have to keep thinking about it. Okay, so there is an image of a child, a newborn who is smiling, which unfortunately you are not able to see for some technical reason. So are you happy if you see a newborn who is continuously smiling? Right? No. Hopefully you won't see it, and many of your young people sitting at the back would have not seen. And that's your rhizus sardonicus. It's your spasm-related smile in a child with neonatal tetanus. And so we say not everybody who smiles makes us happy. And similarly, this is anthrax. You have day 1, looks like a vesicle, then gets into eschar formation, and then you have a very bad gangrenous patch seen over there. Similarly, you might, hopefully will not see a plague again. That's your bubonic plague. There's a lymph node and a very sick child. And of course, we don't want to see this again. This is polio. Hopefully, we have eradicated it for good. And I don't think many of us have seen this. This is smallpox. But we will continue to see some of these things which are not usual. So you have a child who has an axillary lymph node, and you can see this hand which is slightly swollen. You have a unilateral isolated axillary lymph node. Please look for any injury marks. This is cat scratch disease, and one is likely to see a lymph node in that. Similarly, you have a child with rat bite. You can see this bite mark over here, and then there will be a swelling and fever, easily treatable with penicillin. So we are looking at atypical features of known diseases. So I wanted to highlight this particular thing. So like Wilson has multifaceted presentation, this character mycoplasma is called atypical, not without a reason. So it has various types of implication. It can have conjunctivitis, it can have oral ulcers, it can have urethritis, penile ulcer, and can have a maculopapular rash. Apart from the standard thing that we all know, we have atypical pneumonia, we have encephalitis and joint problems and so on and so forth. Similarly, you can have a cervical lymph nodes, or you can have skin manifestation of a tuberculosis, meaning mycobacterium I should say, that means non-tubercle mycobacterium, okay? So just in this short time of this journey, I have tried to cover infections which were forever present, whatever new infections came. Of these new infections, some of them re-emerged, or the old infections which re-emerged, and their atypical presentations. Fortunately, we have been able to control some of them and hopefully have eradicated some for good. Thank you very much, and I extend my invitation through this new Atal Setu, which is now a new gateway to Mumbai. Thank you.
Hello. Hello. Thank you, Dr. Maniyar, for your excellent picturesque presentation. A real innovation, I say. And we are speechless. Second thing, I may think that this is something different which we have heard before. And it is more of a like, not the Leonardo da Vinci's Mona Lisa, but can be Van Gogh's Starry Night. Wonderful. So many things covered together.
Thank you.
Dr. Naresh Taide, he is President IIP Amravati and Associate Professor Medical College Amravati.
Yeah. Thank you, sir. Thanks organizer Kapicon for inviting me for this presentation. And after previous excellent presentation by sir, you may be afraid that now this is the somewhat boring topic in our UG and PG days, which we always tried to avoid. कि genetic test या फिर genetic diagnosis करके क्या होने वाला है, it is बहुत difficult है और क्यों सोचने का, क्योंकि कोई इलाज नहीं है. So now I am here to help you to diagnose this condition and how you should choose the right test for diagnosis. That is also we are going to discuss. But why doing diagnosis is important in genetic testing and why to choose right genetic test is important, because genetic diagnosis is from worm to tomb. That means once you label one of the patient with genetic diagnosis, he is going to have it for lifelong. Now technological advances is there and the diagnosis is becoming easy with the available test. Genetic diagnosis give a lot of psychological burden to the family. So giving right diagnosis is very important, and I always tell that before doing the genetic test, you should have done pre-test counseling, and after diagnosis, you should require to have a post-test counseling similar to HIV. And the cost of tests are high. Now, the test cost becomes less than the previous, but still it's high compared to the other tests. So, while choosing the test, we should be careful. And there is a lot of difference between the test coming positive and patient really having that diagnosis. So, whether the diagnosis we assume is correct or whether it is really going to have that disease or not, that is the matter of expertise. Learning objective of my talk is, in home, we should go for the genetic testing, which testing we should choose, basic of some genetic testing, indication of each test, and some take-home messages. And all this discussion is going to have a case-based discussion. And my aim is to tell you how you should choose the diagnosis. So it should be interactive. I request to participate in this discussion. So this case 1, I know most of you know the diagnosis. What is the diagnosis? Down syndrome. Very good. And what test you are going to choose? Chromosomal. Very good. So it is known as a gestal diagnosis. So you look at the face and you know the diagnosis. That is known as a gestal diagnosis, and we know this child is suffering from Down syndrome, and no fancy test is required. Doing karyotyping is enough to have the diagnosis. So this karyotyping is done. What is showing karyotyping? Trisomy 21 or pre-trisomy. If any other there defect in this karyotyping report, so there is a translocation. So along with the trisomy, there is a translocation between 9 and 13 chromosomes. So whether translocation is going to have any problem in this child? No, because it is a balanced translocation. But once you got this karyotyping report, it is necessary to test the parent to know whether they have also this translocation or not, so that because they may have the history of recurrent abortion if one of the parents have same translocation. Another test, if any other test can be done for Down syndrome. If you have a child with Down syndrome, karyotyping till 14 to 15 days, and then parents want earlier diagnosis. So if you any test, you can do FISH, very good. So doing FISH is going to help, and in this you are seeing these 3 which tell you that this child has trisomy 21. But for doing FISH, it is necessary that you must have your diagnosis in your mind. So if you don't know whether this child has a trisomy 21 or trisomy 13 or trisomy 18, and you do for testing for the FISH for the Downs, then you may get only thing to know that this child doesn't have the Down syndrome. But any other disease is not, that cannot be told. This is the chromosomal level defect. We are going to do karyotyping. If it is a smaller deletion or duplication, we are going to do the microarray. And for the base pair change, we require to do the NGS testing. NGS testing is what? What is the long form of NGS? Next generation sequencing, and not genie at your service. So now sometimes lab people so much of talk about the NGS testing or next generation sequencing, whole exon testing, whole genome things. We think if we don't know the diagnosis and we send this test, we are going to get the answer. But not this so. So we have to remember that this is not a genie at your service which give you the solution of every your case. So these chromosomes, all of us know that they have 2 arms, pre-arm and Q-arm. So what karyotyping will do? Check whole genome at a lower resolution. It shows change in number, large structural variation, translocation. When you should do it? If you suspect chromosomal disease, to know the genetic sex in disorder of sexual differentiation, female with primary amenorrhea, short stature, hypoplastic uterus, recurrent abortion. If there is a ring chromosome translocation and inversion, in this case, no other test is going to give you the diagnosis. Only karyotyping will going to help you. And in some cancer disorder also, karyotyping will help. Most important is when not to do. So, if you are suspecting the single gene disorder like sickle cell or thalassemia, then karyotyping is not going to help you. If you are suspecting microdeletion syndrome like DiGeorge syndrome or Williams syndrome, then karyotyping is not going to help you. So we should not do karyotyping in that case. This is a second case, SAJ family. This is the relative of doctor family. They come for antenatal counseling because their first girl child has mild autism with ADHD, born full term by cesarean section with birth weight of 2 kg, meconium stage liquor, cried immediately after birth but required 1 month hospitalization, and diagnosis kept was meningitis with convulsion with non-oligemic renal failure. EEG was done at 14 months, show epileptiform discharge, MRI show mild prominence of ventricle with frontotemporal atrophy. They shown to the neurologist, pediatric neurologist noted hypotonia with future of ADHD, autism, and he rightly think of some genetic disorder, and he done the clinical exam. Now report come normal. So what I'd say ki NGS is not a genie, he not give every time you the diagnosis. So what next? Whether we are dealing with autism or ADHD, which is sometimes may be non-genetic, whether it is a cerebral palsy. If it is a cerebral palsy, so I told them that if the child has autism, as per ACMG, first line test means we require to do the microarray, and microarray may be positive in 40%, not that every child get positive microarray, but as they want to have a second pregnancy and to know whether their second child is going to be affected with same or not, they are ready to do the testing because they are belonging to the doctor's relative, and this test was done and it confirmed the diagnosis that this child has 15q13.3 microduplication syndrome, perfectly fitting with the picture of that child. So sometimes NICU stay, prolonged NICU stay, meconium stain liquor, we are going to label them as a cerebral palsy. I always request, whenever I go to any forum, I always request that don't label the patient with diagnosis, especially chronic one disease. Because what happens, once you label them, no one will going to think beyond that. Once you label the child with CP, he remains always CP for lifelong. Once you label the child with autism, he'll remain as autism. So microarray give better resolution, like doing the X-ray in the X-ray is like karyotyping, and microarray is like a CT scan of lung. So resolution is 10 kb, which is 15-fold higher than karyotyping. Different type of microarray may have different resolution and detection capability, and these are the guidelines. Microarray is now first line test for unexplained intellectual disability, multiple congenital anomalies, autism spectrum disorder, and fetus with malformation and very high NT, we should go for the microarray. If the NT value is more than 3.5, then first line test may be the microarray over karyotyping. And when not to do? Again, so if you have the family who has the recurrent abortion and the POC is not tested, and you want to do the parent test, which testing you are going to do? Parents are normal and you want to do the parent test, which testing you are going to do? So you require to do karyotyping because there is a balanced translocation, and balanced translocation cannot be picked up by the microarray. So inversion cannot be picked up by the microarray. So we cannot do their microarray. When there is a single base pair deletion, like again sickle cell disease or thalassemia, microarray will not going to help you. You require to have a different testing. This case 3 is there, PJG, 7-year-old, referred for obesity and delayed development. Height is 113 centimeter, weight 30 kg, full-term normal vaginal delivery, birth weight 2.75 kg, cried immediately after birth. There is a difficulty in feeding, taking feeding, poor feeding, so required NICU admission. And then initially he is present as failure to thrive because of feeding difficulty, and after 1 year, child started gaining weight. He also had a polyphagia. Gone to endocrinologist, evaluation for thyroid and Cushing was done and come normal. I think most of you again on history can have the diagnosis of this case. What is the diagnosis? Prader-Willi syndrome. Excellent. So this is the case of Prader-Willi syndrome. And what test you are going to choose? What? So what test you are going to choose? In this, ideal test is a methylation specific MLPA and not karyotyping or NGS. Here required methylation specific MLPA, but approximately 40 to 60% cases of Prader-Willi are due to deletion. So in our region, where means most of part of India, cost is the issue. So I choose this test which done at a lower cost, and we can get the diagnosis. And as it is a deletion, we are able to pick up with this test. But otherwise, if it is due to the methylation defect, then methylation MLPA is the test of choice rather than doing simple MLPA or microarray. So MLPA test can detect 40 to 50 different genomic segment, And it is the first line test for DMD, SMA, myotonic dystrophy, and sometimes some mental retardation panel. Like in this, they are doing 10 to 15 disorder in the single test for MLPA. So again, like fish, for MLPA also, if you want to do MLPA, you should know what you are looking for. So if you suspect DMD, then you can do MLPA for DMD. If you suspect SMA, then you can do MLPA for SMA. But if child is hypotonic, like in this Prader-Willi, child has Prader-Willi and you do test for SMA, then it's going to come as a negative test. This case 4, a 6-year-old child with walking difficulty, not able to stand from sitting position, calf hypertrophy is there, and this is his video. So what is the diagnosis? Duchenne muscular dystrophy, right. So what first biochemical test you are going to do? CPK, very good. CPK, NAC or total CPK we are going to do. And this is 5,600. So next test, genetic test, which? MLPA. As we already discussed, that is a 79 MLPA for DMD. But it comes negative. Now what? If this child has DMD or not? So we require to do the next testing. It is a NGS testing, because we have to remember that only in 60% of cases or 70% of cases, 60 to 70, you can get MLPA positive. Remaining 30 to 40% of cases are due to single gene mutation in the DMD. So we require to do the NGS test to confirm the diagnosis. And this is our data of 101 patients with suspected DMD, out of which only 83 patients are able to do the complete test, which include MLPA and whole exon. And out of that, only 79, means 95% patient has confirmed with DMD. But 4 patients are there which typically like DMD, but they doesn't have DMD. So this typical presentation, because DMD is a monomorphic disease. Any patient you get with the calf hypertrophy, difficulty in getting up from sitting position, you label him as a DMD, but it is not. We have patient with SMA who label as DMD since childhood, and at 18 and 20 years, I diagnose him as a DMD. One patient who received stem cell therapy, suspecting him as a DMD, and later he found to have a LGMD after genetic testing. So this can happen. So monomorphic disease, this is the problem. You know this is the clinical picture, and we're going to label it as this diagnosis is there. So next generation sequencing, it is the advanced version of sequencing. It is a massive parallel sequencing of multiple genes simultaneously, used for single base pair mutation, small insertion, deletion, etc. And when not to do, if you suspect Down syndrome, no need to do the NGS sequencing. If it is a Dijor syndrome, no need to do the NGS testing, because it may not pick up. This case 5 is there, 6-month-old male, known case of congenital dyserythropoietic anemia, on regular transfusion since 3 months of age. At first BT at 3 months, testing show hemoglobin of 1.8 gram, RBC 0.56, MCV 87.5, MCHC 36.73, received 3 BT till 6 months. He was evaluated and labeled as a congenital dyserythropoietic anemia. His cousin brother, known case of thalassemia major, receiving transfusion from 3 months of age. Father of this child, HPLC show thalassemia trait, and mother is normal. At 6 months, he presented to me with severe anemia, no palpable liver, spleen, retic count was 0.5%. So what is the diagnosis in this child? If this diagnosis is correct, or whether this child has a thalassemia major or any other diagnosis. So this is the pedigree. We have done the genetic testing and found that this child is suffering from the diamond black fan anemia. Started on omnocortil, And now he is 10-year-old, doesn't require single transfusion after that, only receiving 1 milligram daily, total dose, not 1 milligram per kg. Now he is just on 1 milligram of dose of omnocortil, and still he is well. So both parents were tested, they are the negative for the mutation, and next pregnancy, the baby was also tested, and that also came to normal. So this changed whole life of that child from regular blood transfusion to no blood transfusion. But most of the patient may not be so lucky. He pick up at 6 months. This is the case, 13-year-old female child receiving transfusion since 4 months of age till 13 years. He came to me with signs of iron overload. Her younger brother also receiving the transfusion. When I go through the record, I find out that this is not looking like a thalassemia. Explain them that not looking like thalassemia, you should check up. But difficult to accept this. Once you told that this child has for 13 years taking transfusion as thalassemia, difficult to accept different diagnosis. After the death of the child, they come. His younger brother was evaluated, and he also found to have diamond black fan anemia. Now since 5 years, his younger brother is also transfusion free. No blood transfusion is required, only on simple omnocortil. So sometimes labeling is very difficult. You don't label unless you are 100% sure, because once you label, no one going to look at the diagnosis. थैलेसीमिया के अपने पास में आते हैं, ब्लड लगाते हैं, चले जाते हैं, ब्लड लगाते हैं, चले जाते हैं, अपन देखते भी नहीं क्या है उसके रिकॉर्ड में, क्या था नहीं था. दिस इज केस 6, HJ, 4 month, 4th child, male child, 3rd degree consanguineous marriage, referred because previous 2 babies death, 2nd suspected to affected with methyl glutaric acidemia on GCMS, and during this pregnancy they came, TMS and GCMS was done at 17 day, it's come normal. So now, whether the child is normal? Not necessary, because previous child was not completely evaluated. This is the whole history of that. I am not going in detail. Now, as GCMS was normal, I told them that we cannot rule out completely the diagnosis. Any problem, you should come immediately. They come at 2 months for convulsion, decreased activity, serum ammonia normal, MRI brain show non-specific change. I suspect some diagnosis, started on treatment, he is better, well. Investigation was sent. And what is the diagnosis? Diagnosis is the biotinidase deficiency. Confirmed with the enzyme assay also. And now he is 1 year old, normal, no convulsion. You can consider 2 child died with simple treatable disorder. Because of what? Because they suspect in second child कि भाई कुछ तो भी metabolic disorder होगा इसको. Because TMS, GCMS comes positive, they don't go for the further testing and confirm the diagnosis, and they miss the diagnosis. This case 7 is presented as ataxia and walking difficulty. This is the family history key. First child is also similar complaint. Their 4th female child also has the similar complaint. 5th child also on examination has mild ataxia. So what is the diagnosis? On clinical examination, we have the diagnosis of Friedreich ataxia. So now which test you are going to do? Whether you are going to do karyotyping, microarray, or NGS testing. So in this, we required a different test, totally different cell, because it is a triple repeat disorder. We require to do TP-PCR. Otherwise, all these tests, 3 tests can become negative. If you do karyotyping or you do microarray or you do NGS, is going to come negative. You require to do TP-PCR to have the diagnosis. So this is the analogy. If you consider that 46 chromosomes are the 46 chapters and each chapter in duplicate except X and Y, then if there is a chapter deletion or some of the pages of chapter is missing, that can be picked up by the karyotyping. If there is a paragraph defect, paragraph is missing, that can be picked up by microdeletion, microarray test. If you read the whole book from first page with index, all these things, references, all this, then that is a whole genome sequencing. You are reading whole book word by word. word by word. That is the whole genome sequencing. And if you do the only chapter you read, not references and all these things, then it is a whole exome sequencing. And if you do like in exam कि important कौन से chapter है और उसमें से important point कौन से genetic का छोड़ दो अपन ने, तो then it is a clinical exam sequencing. So this is the very sensitive mnemonic. If you follow this, you are not going to miss the genetic disorder because they are not presenting, coming to you as a कि भाई मेरे को fever है तो मेरे को typhoid है या फिर मेरे को rash है इसलिए मेरे को measles है इसलिए. So if you are not sure, always take consult with your colleague who is interested in genetic diagnosis. That is, not sure means if patient is non-responder, if there is a sudden deterioration or death, unexpected symptoms, if there is a recurrent history, unexplainable, कि 2 vomiting हो गई, patient shock में आ गया, 2 vomiting के बाद में क्यों shock में जाना चाहिए? Whether we are dealing with organic acidemia, take home message, if you know the gestalt or clinical diagnosis, can do specific test. If you don't know, can discuss with friends having genetic knowledge, like Kore sir here, who can help you. Always do with pre-test counseling and after post-test counseling. This is very important. We order the test, but we don't tell them what this test is going to do. What if comes positive, what if comes negative. And so there is a issue. Because न्यूबॉर्न स्क्रीनिंग अपन करते वो नेगेटिव आ जाती, पेशेंट को लगता मेरे बच्चे को अभी कोई जेनेटिक डिसऑर्डर नहीं होगा. एंटीनेटल इसमें डबल मार्कर कर लेते, उसमें लगता उनको लगता मेरे बच्चे को डाउन सिंड्रोम नहीं होने वाला है. दिस इज नॉट ट्रू. यू शुड explain them. Not all disease can be diagnosed with whole exome sequencing. In that matter, whole genome sequencing also. Not all genetic disease can be diagnosed with genetic testing. And if you can't have specific diagnosis, always better to have geneticist opinion before testing, because these tests are costly and no one going to repeat that. So these are the some genetic course you can register if you are interested. Thank you. Thank you very much.
Thank you, sir, for making this so-called phobia topic or difficult topic. You made it very simpler. And take home is always, whenever there is a dilemma like think we should do, and we should go for genetic testing. Excellent presentation, sir. Thank you.
Thank you.
Thank you, sir, for throwing light on this arcane chapter of genetics. I request the chairpersons and the speaker to proceed for felicitation. Now we shall soon begin with our inauguration ceremony for Kapicon 2024. Tea shall be served in the auditorium itself while we make arrangements for the ceremony.